Hello, brothers and sisters of the Desert Southwest Annual Conference. My name is Khalif Smith. I am your core chairperson and chairperson for the RACE Coalition. We are coming to you with a special conversation on health issues and health disparity in the communities of color. This is a reflection for our Black History Month. And we are joined today by Kristen Hansen, who is co-chair for our health and caring ministries within the annual conference. I want to remind you that the RACE Coalition is reflection, action, courageous dialogue, and engagement, and would like to continue the conversations that pertain to not just racial issues, but awareness of issues in communities of color. So without further ado, I'll turn it over to my co-chair, Ephraim Zavala, and he will do a brief introduction.
Dr. Kirk A. Johnson is an assistant professor of justice studies and medical humanities. He received his Master's of Divinity from the Drew Theological School, and his doctorate in medical humanities from Drew University. He is a member of the American Society of Bioethics and Humanities and the New York Academy of Medicine. He serves as a member of the Atlantic Health Systems Bioethics Committee, former assistant director of the Medical Humanities program at Drew University, and fellow emeritus of the American Heart Association's Multicultural Initiative Leadership Fellowship Program. Dr. Johnson has published articles in peer-reviewed journals and upcoming contributions in numerous books. His recent books are the Anti-Racism Resource Guide, Volume 1, Supporting Black Businesses and Economics, published in 2020, and Medical Stigmata, Race, Medicine, and the Pursuit of Theological Liberation, published in 2018. He is the co-host of the Bioethics in the Margins podcast series. He is an ordained clergy in the United Church of Christ, where he serves as a member of the board of directors of the UCC's Central Atlantic Conference, secretary of the UCC Central Atlantic Conference's New Jersey Association, a member in the Summit Interfaith Council Anti-Racism Committee, and creator of the Race Talk Origins and Race Talk Systems courses. We're very excited to have him here with us. Thank you for joining us, Dr. Johnson.
Absolutely. And you missed one amendment to my bio, is that a good friend and colleague of Reverend Ephraim Zavala, which is also a very important designation. And I am very grateful and thank you for the opportunity to share as health and ministry go together and they go hand in hand. It is called holism, right? You can't just focus on your spirit. Yes, your spiritual well-being is important. But Lord, we have known, especially the past couple years, that our mental health, as well as our physical health and well-being, are equally important. And all those three dynamics that we have, if one is off, then that also impacts the other two dynamics of who we are. So we're going to talk a little bit about that specifically in communities of color, in the Black experience, in the African diaspora. I want to talk a little bit about reflections on church and health equity. Of course, a shameless plug, one of my books that deals with racism in medicine. It's called With a Theological Liberation Lens and Twist on It, specifically Black liberation theology. My book, Medical Stigmata, Race, Medicine, and the Pursuit of Theological Liberation, which is available wherever books are sold. So definitely like to hear your thoughts on the book once you get a copy of that. So we're going to look into a term called the social determinants of health. So according to the CDC, which is the Centers for Disease Control and Prevention, social determinants of health are conditions in the environments in which people are born, live, learn, work, play, worship, right, and age that affect a wide range of health, functioning, and quality of life outcomes and risks, right? So the social determinants of health literally is every dynamic, every condition, whether social, economic, physical, and of course, spiritual, that you're in on a day-to-day basis. Some settings will be school, church, your workplace, and of course, the neighborhood that you live in. And these individual locations refer to place, right? Now, there's a difference between place and space, right? Place is an actual location, right? It has an address, right? As I previously mentioned, schools, churches, workplaces, your home, the neighborhood you live. But there's also a dynamic that we also have to look into called space. Space is something that is intangible, that you can't touch. A space is a particular element in which you feel free or you feel constrained, right? And these two dynamics of space and place, right? Again, place being tangible, that you could see, touch, feel, and space, which is intangible. It's about the actual environment, something that you really can't see, but you feel in your body, your mind, and your spirit. And these two dynamics are very important when we look at a holistic approach to health. So in addition to more material attributes of place, the patterns of social engagement and sense of security and well-being are also affected by where people live, right? So resources that enhance quality of life can have a significant influence on population and health outcomes, right? So churches, right, meaning not the people, because we are the church, right, but the houses of worship ought to be or should be a particular place, right, a location where there are resources that impact and help not just the spiritual dynamics of people of God, right, but also the mental and the physical health and well-being of children and people of God. Right. Examples of this, and of course, I know that the UMC has different programmings and different departments, conference-wide, but also nationally, to include safe and affordable housing, which is huge. We just are still in COVID-19, but a huge safety guard was the eviction and moratoriums federally and also statewide throughout the country that prevented people from being homeless because they lost their jobs through the collateral damage of COVID-19. And statistically speaking, the demographics that were impacted the most were Black and Latinx, as well as Asian and Pacific Islander communities. So that moratorium, which obviously was lifted earlier this year federally, but also in other states as well throughout our country, really prevented a lot of collateral damage so folks could stay safely in their homes and try to avoid getting sick from COVID-19, which obviously would have been exacerbated if they were homeless and out in the street. Also, access to education, public safety, availability of healthy foods, which is a big problem right now with inflation. Food prices have skyrocketed, so food insecurity, not just for adults, but also for children. Another interesting statistic, particularly in communities of color, Black and Latinx communities specifically, is that the majority of school children get their food from being in school and attending school. So a consequence of COVID-19, for an example, when things were forced to be online, really changed the dynamic of nutrition for children, specifically Black and Brown children. Local emergencies, health services, and environments free of life-threatening toxins. And there's many more examples, but these are what is described as the social determinants of health, the different social influences that impact everyone's health, including communities and people of color. So I already went into some factors previous slide, but I definitely want to highlight the last two actually all three particular points. So the biggest thing is, for the first point here, is getting recommended immunizations and screening tests and seeing a doctor when we are all sick, which really influences everyone's health, right? Particularly regarding vaccinations for COVID-19, which is now readily available in majority of pharmacies, right? And I know each state is different regarding the dynamics of this, but even now we still have a huge percentage of people who are not vaccinated, dominantly in African American or Black and Latinx communities. And every time I do a presentation, or even if I teach a class, I always recommend my students, as well as our parishioners, our congregants, to get vaccinated. Statistically speaking, if you are vaccinated and you catch COVID-19, it will hinder you from getting dramatically ill that you need to go to the hospital or even die of this particular illness. Specifically, the last two variants, the Delta variant and the more recent variant that really spread throughout our country rapidly, the Omicron variant. A second point I want to mention, our health is determined in part by access to social and economic opportunities, right? So here's another thing I think the church can really continue to be a light in granting access to our congregants, maybe partnering, for example, and I'll talk a little bit more about this specifically, with local health organizations and hospitals to provide the resources, not just COVID-19 vaccinations and other things related to the pandemic, but just health in general. Right. So this is really looking at the church in the 21st century, right? Not just a church of a place of worship, but a church as a community center, which obviously is not a revolutionary thing. Churches are community centers, but just being more focused, not just on the spiritual dynamics, but the physical and psychological dynamics of congregants' health. And it doesn't matter if you have 50 people in the church or 5,000 people in the church. There's different ways that each church could be effective in their own way in their communities with partnerships and resources, which I'll go into a little bit later. The third is the quality of our schooling, right, which is extremely important. And I'm not saying that the church should directly be a part of that, but really encouraging parents and communicating with parents to see what is the environment in the learning of our children, right, and the safety and health efficacy of our children as well. Where we work is also important, and of course the cleanliness of our water, right? I know what made national headlines years ago was Flint, Michigan, on how horrible the plumbing and the system is, particularly in poor areas where Black and Latinx individuals live, right? As well as food and air, right? We have it's not a surprise that we have an issue with climate change that impacts not just our climate, but our food regarding agriculture, right? Air, the air we breathe, right? All these things are connected to our health. So they're not mutually exclusive, but they're interconnected into how we live and how we live in our health and well-being. Right. So these are important factors that we should also consider. So a quick context of communal health. These are the top 10 things that really emphasize the quality of life and indicators for health and quality of life for communities. So access to recreation and open space, right? That you could exercise, you could ride your bike, you could run, you could walk. Access to healthy foods, right? Access to medical services, access to public transit and active transportation, right? This is big, especially if you live in a rural area where the closest supermarket or medical facility might be 50 miles away, right? Maybe looking into creating projects to have essential services like this closer for rural communities, right? Access to quality, affordable housing, right? Part of inflation is not just food, but also the rising costs of paying rent, right? And of course, mortgages, which are very important. Access to economic opportunity, completeness of neighborhoods. 8 is safe neighborhoods and public spaces. 9, environmental quality. And 10, green and sustainable development and practices, right? Being ecologically sound and friendly, right? So these are 10 indicators that really will help the health and well-being and the quality of life of our congregations and the communities that surround our congregations. Now, looking at the 10, you could probably name, if you have all 10, you are very fortunate, but also very lucky and rare, because it's very rare that a community has all 10, unless you're super, super wealthy. And there's very few places throughout our country, not just through Arizona and also in New Jersey, where I am based out of, that have all 10, right? So there's always something that we could work on community health and wellness. The partnerships, right? So I am UCC. I'm part of the United Church of Christ as a fully ordained minister and elder. But of course, within our brothers and sisters in the United Methodist Church, there are organizations that, if you haven't already, I encourage you to reach out to at the local, state, and national or conference level to see if there are partnerships that could be developed if they aren't developed already, right? Too often, in especially mainline denominations like that we belong into, the national setting sometimes is disconnected with the local setting, right? And it's not intentional, of course, but it just happens. We're so busy in our local and state settings that sometimes we don't have time to adequately communicate with the higher levels regionally and nationally, right? But of course, what COVID has taught us is that every level is integral in what we need to do, from the national all the way to the local setting, right? So, so for United Church of Christ, CHISM, the Council for Health and Human Service Ministries, these are partnerships that are quickly developing or rekindle or reconnecting. So there'll be instances where churches haven't really reconnected with our national body, which is CHISM, that through COVID, we have reconnected and maintained connection for not just monetary resources, but also other resources, providing medical resources for congregants that might not have access to these, especially if you're in a rural area, right? So these are things that I think we ought to, if it hasn't been considered, I encourage you to consider and reconsider these particular partnerships and connections. Also at the state level. So for example, and I know this varies state by state, but in, I believe, yes, last year in 2021, New Jersey created its official health insurance marketplace. So before, through the former President Barack Obama, he created health insurance at the federal level. We call it Obamacare, right? But the actual law is the Affordable Care Act, right? And newsflash, they're not two separate things. I know there was miscommunication that Obamacare is different from the Affordable Care Act. No, Obamacare and the Affordable Care Act are the same thing. The nickname for the actual Affordable Care Act is called Obamacare, which is still implemented nationally currently, right? But I know some states created their own health insurance marketplace. right? And a lot of people in New Jersey specifically, again, where I'm from, did not even know. So as a clergy and as a community advocate for health, spread the word, send flyers to churches and pastors of churches to say, if you have congregants that do not have health insurance, sign them up, and they're in New Jersey, they are eligible to be under the Get Covered New Jersey health insurance marketplace, right? If you are in a state that does not have a health insurance marketplace, the Affordable Care Act is still available and implemented that they could get health insurance, especially during a pandemic. It is something that is very important to have. And even after the pandemic is over, which I'm sure all of you agree with me, hopefully it will end tomorrow, which obviously is not a realistic expectation, but hopefully sooner than later. Things happen, right? And accidents happen. And it's good to have health insurance as a backup. Because we are in a society, a capitalistic society, that health insurance is linked with money and access. And if you're sick and you don't have health insurance, you could easily get into debt with tens of thousands, if not hundreds of thousands of dollars. So the Affordable Care Act, if you do not have state health insurance, is something that I highly suggest for all of you to really tap into, if you haven't tapped into those resources already. Also, another mainline denomination, the National Baptist Convention and also the Progressive Baptist Convention has a particular initiative called the Health Outreach Prevention Education, HOPE for short. And this particular initiative, along with Progressive National Baptist Church, their particular program really impacted around over 1,100 Black churches in 22 states, right? And the National Baptist Convention also has really, regarding the Baptist denomination, which is dominantly Black Baptist, compared to the American Baptist, which is more dominantly white-based, but also very diverse particular denomination. These particular health outreaches and initiatives really bring health in the forefront for these particular Christian mainline denominations. Right. So for the United Methodist Church, particularly, if there is a initiative that needs to be revisited, or if there isn't any initiatives at all, and you're like, you know what, we really think we really should have an initiative and partner together to have an initiative locally, but also at the state and conference level, that could be something that could be revisited. Right. And again, this is a presentation just to give ideas regarding health equity, because all the things I'm saying right now is connected to more vulnerable populations, which are communities of color, regarding access or lack of access to health and wellness and other initiatives that are interrelated with those things. So a little bit about my work and encouragement to do this is partnering with local, national health initiatives. So on the left, I used to be a fellow for the American Heart and Stroke Association, and I believe this picture was taken at a senior citizen home, right? Making them aware of healthy eating and making sure they get their blood checked and making sure they get check their heart regarding EKGs, right? And echocardiograms as well, because stroke and heart attacks are one of the leading causes of death that are preventable, purely preventable, just by having regular checkups and going to the doctor's office. On the right here is the Lupus Foundation, and this is actually a healthcare fair. I used to be a part when I used to be a part of a previous church. I'm no longer affiliated with them. We had annual health fairs for our community that we invited different foundations, health foundations in the community to come and distribute information for particular illnesses and diseases that impact our congregants. So in this particular setting at the church, there were a lot of individuals who had lupus. So we invited the Lupus Foundation to connect them with doctors that specialize in lupus, but also have information, because knowledge is power. So the more you know about your illness or disease, or just know about health and prevention in general, will be beneficial to congregants, but also not the congregants as well, but clergy. There are tons of clergy who actually came, who weren't affiliated with the denomination of that church, that came and actually brought back tons of different materials for their congregations to use. Because health and wellness isn't something that is just limited to the UCC, right, or the UMC, United Methodist Church. It's for everyone, right? And so that was the point of the health fair that we have every year. And I believe this church still has it every year, to educate and to empower and to have preventative means to empower our congregants, but also the local community. We also had a nutritionist. So on the left, a colleague of mine who still does nutrition came in and really explained sugar intake. I think this was a picture here, how much a bottle of Pepsi has of sugar, which is a lot, way too much grams of sugar. So the majority of illnesses and diseases that we have is based on what we put in our body, right? So just being more mindful of what we put in our body and being more educated about things like trans fats and sugar and salt and all these other different things that if we're not careful, we're putting in our bodies and that could contribute and cause sicknesses and illness. And then on the right, ACA, the Affordable Care Act, which I mentioned, these are two licensed individuals and professionals that are licensed to sign up individuals for ACA. So you could do it online, but there are also health insurance individuals that also go out to communities and sign up individuals who do not have health insurance. So instead of congregants going and trying to go online and sign up, if they don't have a computer or if they have a hard time with technology, you can invite individuals to your congregation, obviously through conversing with the boards of your fellow churches and congregations to see if this is a process that is attributable to you. And if everyone agrees, having folks come and sign up congregants to their ability to sign up for health insurance, right? And this was also part of the health fair that we had at the particular house of worship that I used to be a part of. Also community events, which are very important. So of course we're in COVID, and people are slowly trying to get back to normal meeting in person. But prior to COVID, we had Zumba classes where individuals dance and exercise and get their blood flowing, right, to alleviate, sitting around all the time, which was very successful. We usually get about 20 to 30 people. I believe we had sessions 2 to 3 times a week. In every session, we had quite a few people to spread out and to do Zumba, right? Now, if you're in a smaller church setting, this could be, compromised. Maybe you have to try to figure out a different way to do this. But if you have an actual fellowship hall where you could actually hire a Zumba instructor, a lot of them do it for free. Some of them just a really modest fee for an hour or 2 hours to get congregants working out and dancing and having a good time, which the past year, which would have been quarantined. So that sounds pretty nice, right? This is something that is fun, that could build community, but also build a particular, what's the word I'm looking for? Mentality, right? And culture of health and wellness within our churches, right? And then Go Red, Women's Heart Health Month, which is actually, I believe, this month in February through the American Heart and Stroke Association, where we focus on women's health, but particularly heart health. Women, particularly Black and Latinx women, are have a higher propensity to have stroke and heart attacks, right? So Go Red for Women, which is this month, is some initiative that if your church really feels strongly about, could actually participate in, right? So these are just different ideas in presenting health inequities within communities of color, particularly health disparities within Black and Brown communities. All of this is interrelated. And I just didn't want to go into the problems because I could just give you statistics upon statistics about the issue. Yes, there is an issue. I'm really concerned about not just addressing the issue, but what can we do? I'm concerned about not just looking at the issue and the statistics, but also addressing the issue. What are some innovative things we could do in our churches, in our communities, that can alleviate the health disparities that we currently have in a applicable way that you don't have to have tons and tons of money to actually accomplish? So the last thing I want to share is a video regarding the discrepancies of health disparities within communities of color. And this particular video explains what is systemic racism, systemic issues on why it results in health disparities and health issues within communities of color. Right? So I'm going to share this video and then open up for questions here.
This is Jamal. Jamal is a boy who lives in a poor neighborhood. He has a friend named Kevin, who lives in a wealthy neighborhood. All of Jamal's neighbors are African American, and all of Kevin's neighbors are white. Because Jamal's school district is mostly funded by property taxes, his school is not very well funded. His classrooms are overcrowded, his teachers are underpaid, and he doesn't have access to high-quality tutors or extracurricular activities. Kevin's school district is also funded by property taxes, so his school is very well funded. His classrooms are never crowded, his teachers are very well paid, and he has access to high-quality tutors and lots of extracurricular activities. Kevin and Jamal live only a few streets away from each other. So how come they're growing up in such different worlds with such different opportunities for success? The answer has to do with America's history of systemic racism. To understand it better, let's look at what life was like for Kevin and Jamal's grandparents. Decades after the Civil War, many government agencies started to draw maps dividing cities into sections that were either desirable or undesirable for investment. This practice was called redlining, and it usually blocked off entire Black neighborhoods from access to private and public investment. Banks and insurance companies used these maps for decades to deny Black people loans and other services based purely on race. Historically speaking, owning a home and getting a college education is the easiest way for an American family to build wealth. But when Jamal's grandparents wanted to buy a house, the banks refused because they lived in a neighborhood that was redlined. So Jamal's grandparents were not able to buy a home, and because colleges could prevent them from attending through legal segregation, their options for higher education were really scarce. Kevin's grandparents, on the other hand, got a low-interest loan to buy their first house and got accepted into a handful of top universities, which traditionally only accepted white students. This opened up a wealth of opportunities that they were able to pass on to their kids and grandkids. Even as late as the 1980s, an investigation into the Atlanta real estate market showed that banks were more willing to lend to low-income white families than to middle or upper-income African-American families. As a result, today, for every $100 of wealth held by a white family, Black families have $5.04. A 2017 study confirms that redlining is still affecting home values in major cities like Chicago today. This explains how Kevin and Jamal inherited vastly different circumstances. Unfortunately, the story doesn't end there. A big part of systemic racism is implicit bias. These are prejudices in society that people are not aware that they have. Let's go back to Kevin and Jamal. Against all odds, Jamal manages to be the only student from his high school to get accepted into a great university, the same one that Kevin and his high school friends are attending. But after Kevin and Jamal both graduate, Jamal notices that his resume isn't drawing as much interest as Kevin's, even though they graduated from the same program with the exact same GPA. Unfortunately for Jamal, studies show that resumes with white-sounding names get twice as many callbacks as identical resumes with Black-sounding names. Implicit bias is one of the reasons why the Black unemployment rate is twice the rate of white unemployment, even among college graduates today. You can see evidence of systemic racism in every area of life. The disparities in family wealth, incarceration rates, political representation, and education are all examples of systemic racism. Unfortunately, the biggest challenge with systemic racism is that there's no single person or entity responsible for it, which makes it very hard to solve. So what can you do? The first thing you can do is work towards becoming more aware of your own implicit biases. What are some prejudices that you might hold that you're not aware of? Second, let's acknowledge that the consequences of slavery and Jim Crow laws are still affecting access to opportunity today. As a result, we should support systemic changes that create more equal opportunities for everyone. Increasing public school funding and making it independent from property taxes would be a great start, so that poor and wealthy districts can receive equal access to resources. Systemic problems require systemic solutions. Luckily, we're all part of the system, which means that we all have a...
So regarding systemic racism, as the video perfectly illustrated, does that have poor health outcomes? Absolutely. The job you have results in good or poor health outcomes. The neighborhood you live in results in good or poor health outcomes. These are other social determinants of health that really aren't looked at as social determinants, but definitely are connected to the health and well-being of neighborhoods, as well as churches, as well as demographically speaking with people of color, and of course, white individuals as well, right? So all of these different dynamics are interrelated. But as I mentioned, I wanted to share solutions first and encourage folks in UMC first about ideas that we could actually quell, or at least try to start alleviate these systemic issues that foundationally were rooted historically, right? So that is my presentation, and hopefully it got some gears turning in all of my brothers and sisters, men and women of the cloth, got your gears turning about how we can actually help and what we could do to be effective, not just regarding social justice as a whole, but obviously in making our congregations and our communities healthier. So thank you for your time.
Awesome presentation. Thank you so much. I'm so moved, and there's so many questions. Honestly, I could probably spend a couple of hours online with you. But I do want to touch on one thing that, you kind of briefly touched on, the idea of getting vaccinated, the idea of health insurance, and particularly for communities of color to follow this path of being involved in the social wellness system, if you will. When we have a history in communities of color of distrust of that system, right? We've seen in the past where medical experimentation and other practices on people of color have built a resiliency and distrust within the communities of color for the established medical or the medical establishment, if you will. What would you say to, as a medical professional, what would you say to communities of color about overcoming those challenges and really beginning to build trust again in public access to medicine?
Yeah, well, first, I don't think that vaccine hesitancy, which I believe you're talking about, is 100% about mistrust. I think that's just one small piece regarding Black and Latinx communities. Of course, of the histories of medical experimentation, that brings about mistrust, but I think there are many other different variables that also create vaccine hesitancy. One of them is access to get vaccines, right? Another a particular dynamic, I believe, is the misinformation about vaccines. the propaganda about, oh, there's computer chips in the vaccines, or it's about, radiation is the aspect of creating COVID, and all these other basically folklore about COVID that is not true, but we take it and run with it. Another is regarding understanding the difference between fact and propaganda. The majority of information we consume is on social media. Social media is not regulated, and social media doesn't have a peer-reviewed process that in medical information specifically is not vetted. So a lot of things that we consume and believe to be true aren't true, right? Another particular dynamic of vaccine hesitancy as well is the understanding of the vaccine between the doctor and the patient, right? So this is a little bit where implicit bias comes in. In medical humanities and bioethics, we call this the doctor or physician-patient relationship, right? This is another level dynamic of trust. And the majority of African Americans, some of them, how can I phrase this? Because statistically speaking, the majority of African Americans do trust their doctor, right? However, there are other studies that will say that there is also discrepancy of trust because of implicit bias between Black patients and physicians as well, right? So it's not just the historical piece, but it's also the current piece, the dynamic between the relationship between patients of color and as well as physicians, right? So it's not just a historical mistrust you were talking about prior. That's one dynamic, but I just mentioned some other variables that hinder people of color, but also people in general from getting vaccinated, but particularly we're talking about communities of color. And these are also variables that hinder people of color to get vaccinated. Now, what is the solution? Number one, really be educated on the facts and know how to decipher credible information with information that is not credible as well. Also, I think there's around 200 plus million folks that have been vaccinated and they're still here today. They didn't grow another leg or another arm. They didn't, nothing obscure has happened to these individuals, right? So that shows that the actual vaccines are safe. And even before the distribution of vaccinations, you have a 3-stage process in a clinical trial that really tested the efficacy and the safety of the drugs, right? So if it wasn't safe, the FDA, I argue, because people will probably argue against me, but if the drugs weren't safe, the FDA would not approve it for emergency use, and then later on and more recently approved it for general use. And I'm talking about the Pfizer vaccine and also the Moderna vaccine as well, right? So these are just different things to really consider. Because unfortunately, when I'm in these conversations, especially with doctors and also other healthcare professionals, or they automatically think all Black people are skeptical. No. There's many other different variables that you have to count into vaccine hesitancy other than the historical mistrust from communities of color.
Awesome, thank you.
Kirk, I wanted to thank you for being with us today, and it was just so insightful. Thank you for sharing everything. And I just wanted to, one of the things that I heard you say was some great ideas for churches to reach out into their communities and make a difference in the lives of other people, like the Zumba classes and the health fairs and, hosting clinics and things like that. And one of the things I heard you say that I thought was so great was that this was not just for the churches, but this was for their community that the churches are in too. Right. That it could be just for your church, but extending that out into the communities too, and making some of those things available so you make an impact in the community. I just thought that was fantastic. Do you have any ideas of how to get the word out into the community for some of those things that you've seen that were effective for some of these special events like this?
Yeah, you could communicate with the mayor. So for example, when we did our health fair, we communicated with the mayor, and the mayor was instrumental in getting different vendors license, blocking out different roads because we needed a lot of space for all of these organizations to come in. Also, you could lead it yourself or partner with other religious communities. So there were a lot of folks, our Jewish brothers and sisters participated, our Muslim brothers and sisters participated, our other denominations within this complexity called Christianity. They came, all the denominations came, right? And fellowship, because ultimately it's about unity for a greater cause, a greater good for all of us to live in unity, right? So these are just some ideas that you could reach out, practical things that you could do, and really effective things that you could do, because now we usually worship on our own, but then probably that could open up a door for you to worship with our Jewish brothers and sisters, right? Jesus wasn't Christian, Jesus was Jewish, right? So to have a little bit more understanding about the life of our Lord and Savior Jesus Christ and his understanding of his Judaism, right? It opened a lot of other different doors just by having that communication of saying, hey, we're trying to be healthy. You want to try to be healthy with us? And usually they say yes. I never heard anybody say no, right? So these are just some other suggestions you could go for.
Yeah, love that. Thank you so much.
You're welcome.
So I really appreciated your emphasis on the prevention of illness, not just the treatment, but also the systemic aspect of health. Because a lot of the times the conversations that we have are about just the individual and what can you do individually to make better choices and be healthier, which is an important thing. But I think particularly this last couple of years with COVID, we have come to understand that health is very much a communal matter, and it's very much a matter of justice. And it's a little bit frustrating sometimes because this goes against many of our culturally or deeply held cultural understandings of health. It's individually, but how can we then begin to promote a more communal understanding of health, where people can understand that, if my neighbor is doing well and is healthy, then that serves all of us, not just myself. I think there's definitely some theological arguments that can be made. There's definitely some, and you talk about liberation. I mean, I think that's wonderful. There's biblical arguments that can be made, but how else can we approach this conversation just so we can let people know or affirm the fact that health is very much a communal effort, not just individual?
Right. First, I think we would have to rethink and revisit our theology of health. Because for us, we usually teach salvation in the many different ways we do as the only form of health. But we also need to incorporate the psychological and the physical dynamic as well as the social, right, dynamic of health. They're not mutually exclusive, right? They're all interconnected. So really having a culture of health. So having sermons that, and this speaking with my brothers and sisters of the cloth, having sermons that look at health, right? And we have chock full of them. The Gospels have so many illness narratives, right? We call them healing narratives, but they're also illness narratives. And Jesus actually does a lot of things socially regarding illness that I think a lot of times we overlook. For example, the woman with the issue of blood for 12 years, right? and Jesus healed this woman, right? What are the social implications of that, right? What are the medical implications of that? So looking in a new hermeneutic, right? I'll use my fancy seminary words, right? Looking in another hermeneutic lens on how we look at the illness narratives and how we preach it with our congregants, but also incorporating the culture of health within our congregations, maybe creating a health ministry where every month we focus on a particular health theme. So say January, we focus on nutrition. February, since it's Heart Health Month, let's focus on, heart health. March, we focus on something like, prevention for cancer or something, right? Obviously, what works for your congregation will not work for another congregation. We're really just having those conversations, just saying, what can we do that is applicable to us? And that could be effective and doable for us. And when you incorporate that intentionally in your sermon and your preaching, intentionally planning events or focusing on things every Sunday, then, that will be something that will be rooted within the culture of your congregation, right? Even, for example, December, we, Jesus's birth. Let's talk about perinatal care, about women's health and regarding baby, so you could twist it in a way that is applicable, that is biblically rooted, but also applicable for your congregants or congregations as well, right? So that's just a practical suggestion I will make.
Yeah, that is really cool. I always think back to the Matthew scripture, right? In Matthew 10, as Jesus calls the disciples, as it's written there, he calls them by name. And then the first thing that he does is he sends them out to heal the sick and cast out demons. And, and he sends them on their way. And then ultimately, he talks about don't take anything for your travels and so on and so forth, and that God will be there with them as they do this work. But it does focus on the health of the community as they are being disciples and spreading the gospel. The gospel is not just the word of God, but health within the community as well. And so I always kind of circle back. That is my call narrative, my call verse, if you will, scripture. And so I think about that all the time in the ways that God calls us to revitalize health within our communities as well.
The other thing,
Amen. I'm looking forward to to hear the sermon. Make sure you record it so I can hear that.
Awesome. I've got it. It's on lock. I'll send you a link to it.
Yes, sir. Thank you.
Another thing that I'm thinking about is that we do have healing services in our book of worship, right? And we could be very intentional in incorporating that in our church services, emphasizing that salvation, spiritual well-being also is connected with our physical, mental, emotional well-being as well. And I think that's just I don't know, it feels like it's something that it's an important resource that we could be using as well in our churches liturgically.
Awesome. Well, we don't want to take up all of your time. We are so incredibly thankful for this time to share with you. Like I said, we could probably go on for an hour or two, but we are so thankful for your being with us tonight, your resourcefulness, and there's so much that there is to unpack in your presentation and in your words. I think this is going to be very helpful for not only our annual conference, but going even further into our communities of faith, so that they might be effective witnesses of God's care for all of humanity through an awareness of health and health issues. The pieces about implicit bias all play a role. The pieces about systemic racism all play a role. But more especially the pieces about communities of faith gathering around each other and really holding true to that commandment that we're given to not only to love God, but to love our neighbor. And so I'm thankful for the ways that you are loving God and the ways that you are loving your neighbors and helping us to love our neighbors as well. At this point, we again thank you for listening. Thank you guys for coming and being a part of the Race Coalition's conversation on health and wellness. And again, the Reverend Dr. Kirk Johnson. And do you have any final words for us?
Oh, no, thank you for having me. And as my friend and colleague Ifrian said, that the past 3 years has taught us is that we really can't go back to normal. We really have to rethink how we do church, not just as a catchphrase or logo, but literally rethink and apply things in a way that will really benefit our congregants and our communities. And health is something that is so huge and is so multifaceted in many different ways. And we have the tools to do it. It's just actually implementing them, using them, and actually doing it, which is half of the challenge. So thank you so much for having me. And if I could be a resource in any shape or form, you know somebody named Ifrian who has my contact information, I'll be more than happy to be a resource.
Awesome. Well, good night, everybody, and thanks for joining us. God bless.